Hi, my name is Laura, and welcome to my audio version of the Family Medicine, Orthopedics, and Rheumatology EOR Study Guide. The rest of the family medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA Orthopedics Rheumatology portion of the Family Medicine End of Rotation Exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. Let's start with back pain. Acute low back pain is defined as symptoms lasting less than 12 weeks. If symptoms last more than 12 weeks, then it's subacute or chronic back pain. Common conditions to know for low back pain are herniated disc, back strain, spinal stenosis, vertebral compression fracture, and spondylosis. Herniated discs are very common. Intervertebral discs are located between each of the vertebrae in the spinal column and basically act as shock absorbers. They're made up of a fibrous outer ring called the annulus fibrosus and have a gel-like center called the nucleus pulposus. When the annulus fibrosus degenerates or is damaged, the nucleus pulposus herniates outward, hence the name herniated disc. Typically, it protrudes posterolaterally, where it impinges on nerve roots, causing sciatica or radicular pain. L5-S1 is the most commonly herniated disc, since it's the lowest movable junction of the spine, followed by L4-L5. The pain often follows a dermatomal pattern, depending on which nerve roots are affected, and is worse with bending or straining. Physical exam will have a positive straight leg test. This test assesses for nerve root irritation, and it's done with the patient lying supine on their back while the provider raises the affected leg upward with the knee straight. If pain radiates down the leg when the straight leg is at an angle of 30 to 70 degrees, then the straight leg test is positive, indicating a likely herniated disc. They might also have a positive crossover test, which is a similar test to the straight leg test, but with the unaffected leg. Definitive diagnosis is an MRI, but this is generally not needed unless pain persists for many weeks. Treatment is rest, NSAIDs, physical therapy, possibly epidural steroid injections, and surgical decompression for very severe cases. Next is back strain, which is among the most common causes of back pain, often due to lifting or twisting. So if you're out on rotations and moving patients, remember to lift with your legs and keep your core tight. Back strain occurs when there is straining or tearing of the paraspinal muscles. Symptoms of a back strain include stiffness and difficulty bending, but there are no radicular symptoms. Radicular meaning caused by nerve root irritation, so no weakness, numbness, or neurological changes. Back strain is a clinical diagnosis. So as long as there are no red flag symptoms, patients with a back strain can resume normal activity as tolerated. Bed rest is actually not indicated here. Treat with NSAIDs, ice or heat, PT, and home-based exercises. A muscle relaxant like cyclobenzaprine might help too. And if there's no improvement after a month, the patient should be reevaluated. Next is spinal stenosis. This is narrowing of the spinal canal, which puts pressure on nerve roots. This causes those radicular symptoms, or radiculopathy, so patients present with back pain with paresthesias that might radiate down one or both extremities. Pain is worse with extension, such as prolonged standing or walking, and it improves with flexion, like sitting or walking uphill. This is because spinal flexion increases the space in the spinal canal. Spinal stenosis is also most common in the elderly, and it's often caused by degenerative joint disease. Definitive diagnosis is done with an MRI, but an X-ray or CT scan can diagnose it too. Treatment is epidural steroid injections, and in severe cases, a surgical decompression, laminectomy, and/or fusion can be done. Next is vertebral compression fractures. These are most common in the elderly, especially those with osteoporosis, but they can also occur as pathologic fractures in the case of malignancy. Patients with vertebral compression fractures present with pain and point tenderness at the level of the fracture. They might have a dowager hump, where their back becomes rounded and there's a loss of height. There is no neurological dysfunction or radiation of pain with compression fractures, just that point tenderness. Diagnosis is done by X-ray. and management begins with prevention. So in patients with osteoporosis, consider bisphosphonates, along with calcium and vitamin D supplementation. Treatment of the compression fracture includes analgesia and an orthopedic and neurosurgery consult, since surgery might be indicated. Last is spondylosis, which is a degenerative osteoarthritis of the spine, of the joints between the vertebrae. This leads to compression of nerve roots and radiculopathy. Patients can present with sensory or motor disturbances, pain, paresthesia, weakness, etc. Pain is worse with extension since that central canal is already compressed, and it improves with flexion. MRI is the best imaging, but diagnosis can be made with CT or X-ray as well. And treatment is NSAIDs, epidural steroid injections, facet injections, and possibly anterior cervical discectomy and fusion surgery in severe cases. So those were a few common conditions, but because this topic can be so broad, a take-home point is that a complete history and physical exam, including a neurologic evaluation, should always be done for back pain. Ask about possible mechanisms of injury, assess for any neurodeficits, determine if there are any red flags that need to be investigated, and decide whether or not imaging is warranted. Most low back pain does not require imaging unless there are red flag symptoms. Red flags of lower back pain include night pain and weight loss, which can indicate a tumor, fever, chills, and sweats, which can indicate infection, acute bony tenderness, which can indicate a fracture, morning stiffness for more than 30 minutes in a young adult, which can indicate seronegative spondyloarthropathy, urinary or bowel retention and saddle anesthesia, which can indicate cauda equina, recent spinal instrumentation, which can indicate a spinal epidural abscess or hematoma, immunodeficiency, which can indicate infection, coagulopathy, which can indicate a spinal epidural hematoma, and extremes of age. These are the red flag symptoms where further investigation of the low back pain is indicated. Fibromyalgia is a condition of widespread chronic muscular pain, fatigue, muscle tenderness, headaches, poor sleep, and memory problems. It is most common in middle-aged women and can be associated with hypothyroidism, rheumatoid arthritis, or sleep apnea. The cause of fibromyalgia is unknown, but it might be due to an increase in pain perception in these patients. Symptoms include diffuse pain, especially in the morning, extreme fatigue, stiffness, painful tender joints, sleep disturbances, difficulty concentrating, and symptoms can get worse with stress. Diagnosis can be made clinically if the patient has diffuse pain in 11 out of 18 trigger points that lasts more than 3 months. A definitive diagnosis is made with a muscle biopsy, which will show a moth-eaten appearance and muscle damage. Treatment for fibromyalgia includes exercise, stress reduction, and other lifestyle modifications. Pharmacotherapy includes antidepressants like duloxetine and anticonvulsants like pregabalin. Osteoporosis is the loss of bone density over time. It's usually asymptomatic and does not become clinically apparent until a fracture occurs. The most common fractures in osteoporosis patients are vertebral compression fractures, hip fractures, and a Colles fracture, which is a fracture of the distal radius from a fall on an outstretched hand. Besides pathologic fractures, other symptoms of osteoporosis might include back pain or deformity, spine compression and loss of vertebral height, and kyphosis, which is that hunchback forward curvature of the spine. The axial skeleton is predominantly affected. Screening for osteoporosis is done via dual energy X-ray absorptiometry, or DEXA scan, and all women age 65 and older should be screened, regardless of risk factors. Additionally, women between menopause and age 65 who have risk factors, like a family history or a low body mass index, should also get a DEXA scan. Remember, women are more prone to osteoporosis after menopause because our estrogen decreases, and we also tend to have smaller, thinner bones to begin with. DEXA is also recommended for any patient with a fragility fracture or who is at risk of secondary osteoporosis, such as patients on prolonged corticosteroids or males with hypogonadism. A DEXA scan is the best test to show the extent of bone demineralization, and the results come in the form of a bone density T-score. Normal is 1 or higher. Once the T-score is down between -1 and -2.5, the patient is said to have osteopenia, a precursor to osteoporosis, and a T-score below -2.5 indicates osteoporosis. Management begins with adequate vitamin D, calcium, and exercise, especially weight-bearing and strength exercises, which can reduce the rate of bone loss. First-line pharmacotherapy is bisphosphonates, like alendronate or risedronate. These drugs preserve bone mass by inhibiting osteoclast-mediated bone resorption, thereby decreasing risk of fractures. Bisphosphonates do have some notable side effects, including pill esophagitis and, very rarely, osteonecrosis of the jaw. Other options for postmenopausal women include the selective estrogen receptor modulator, or SERM, raloxifene, as well as the hormone estrogen. Raloxifene reduces progression of osteoporosis and is also protective against breast cancer. Estrogen, however, does have an increased risk of breast cancer and endometrial cancer, as well as blood clots. Some other uncommon options are PTH therapy with teriparatide and calcitonin, which is last line. Osteoarthritis is a chronic disease of cartilage damage and degeneration in the joints. Within each joint, the bones there have a layer of articular cartilage that reduces friction and allows them to glide against each other, and synovium fills the inside of the joint space. Chondrocytes are the cells responsible for maintaining that articular cartilage. During joint injury or inflammation, chondrocytes repair the cartilage, but over time they aren't able to keep up with the collagen production, causing weaker cartilage with reduced elasticity and eventually breakdown. So in osteoarthritis, there is a progressive loss of the articular cartilage, leading to friction within the joint. Osteoarthritis is most common in weight-bearing joints, like the knees, hips, and spine. It can also appear in the hands, especially in women. Risk factors include age, inflammation and joint injury, mechanical stress, and obesity. Patients present with evening joint stiffness because the condition worsens throughout the day and improves with rest. A crepitus or grating sensation might develop, as well as decreased range of motion. Also, there is an absence of inflammatory signs, but they'll present with pain and hard bony joints. These hard bony joints are a result of osteophytes. Palpable osteophytes at the distal interphalangeal, or DIP joints, are called Herberden's nodes, and osteophytes at the proximal interphalangeal, or PIP, joints are called Bouchard's nodes. And just note, osteoarthritis does not typically affect the metacarpal phalangeal, or MCP joints. So if you see that on the exam, think rheumatoid arthritis instead. Osteoarthritis can be diagnosed with an X-ray, which will show narrowed joint spaces, osteophytes, and subchondral bone cysts, or sclerosis. The preferred treatment is acetaminophen, since it doesn't have a bleeding risk, but NSAIDs are more effective. Other options include intra-articular corticosteroid injections, sodium hyaluronate, glucosamine, and chondroitin. In severe cases, joint replacement surgery might be necessary. Rheumatoid arthritis is a chronic systemic inflammatory disease with persistent symmetric polyarthritis of small joints, bone erosion, cartilage destruction, and joint structure loss. So basically, patients present with pain and stiffness of the hands and feet bilaterally, often the MCP or metacarpal phalangeal joints, PIP or proximal interphalangeal joints, MTP or metatarsal phalangeal joints, eventually the wrists, ankles, and even shoulders and knees as the disease progresses. And again, it's symmetrical, so both sides equally. And it gets worse with rest. So rheumatoid arthritis, or RA, patients wake up with joint stiffness that lasts about a half an hour in the morning, but improves throughout the day. And this is in contrast to osteoarthritis, which gets worse throughout the day with continued use. So these stiff joints get swollen, tender, erythematous, and another word that's used is boggy joint. Rheumatoid arthritis also presents with a prodrome, which includes fevers, fatigue, weight loss, and anorexia. There are a few specific joint deformities that occur as RA progresses, and these are probably good to remember for exams. A boutonniere deformity is flexion at the PIP joint with hyperextension at the DIP joint. So basically, you can't straighten the middle joint of your finger with this deformity. A swan neck deformity is the opposite, hyperextension at the PIP joint and flexion at the DIP joint. So it does kind of look like a swan neck, I guess. Another deformity is ulnar deviation at the MCP, or metacarpal phalangeal joint. RA patients are also more prone to Baker's cysts. What happens is that fluid from the swollen knee fills the semimembranous bursa and causes the synovial sac to bulge posteriorly into the popliteal fossa. So manifestations of rheumatoid arthritis outside of the joints is mostly due to inflammatory cytokines and can include fever, malaise, weakness, and low appetite. And this is that prodrome mentioned earlier. Another manifestation is development of rheumatoid nodules in the skin, which are collections of macrophages and lymphocytes with a central area of necrosis. They typically occur at pressure points, like the elbow, but can present in other areas too. RA patients also have an increased risk of atherosclerosis, anemia, interstitial lung fibrosis, and pleural effusions. Rheumatoid arthritis typically affects women more than men, and smoking is a known risk factor. Diagnosis is made by blood test. The best initial test is rheumatoid factor, which is sensitive but not specific since it comes up in other conditions. The most specific test is anticyclic citrullonated peptide, or anti-CCP antibodies. These patients also have increased CRP and ESR. Diagnosis might be suspected clinically by a presentation of arthritis in 3 or more joints with morning stiffness that has lasted more than 6 weeks, or even presents with anemia of chronic disease. The main X-ray finding in rheumatoid arthritis is narrowed joint space, as well as decreased bone density and bony erosions. Symptom control is managed with anti-inflammatories, so NSAIDs are first line, and corticosteroids are second line for pain control. But the cornerstone of treatment for RA is prompt initiation of DMARDs, or disease-modifying anti-rheumatic drugs, which will reduce permanent joint damage. First line is methotrexate, which is often used as monotherapy for RA, and other options include hydroxychloroquine and sulfasalazine. Biologic agents are another option, and these in general target cytokines and their receptors, or are directed against surface cell molecules. Reactive arthritis, also called Reiter's syndrome, is an autoimmune response that occurs after an infection, often a sexually transmitted infection or gastroenteritis. STIs like chlamydia and gastroenteritis pathogens like Salmonella, Shigella, Yersinia, or Campylobacter are all gram-negative, so they have lipopolysaccharides on their surface. These molecules are also known as endotoxins, and they produce a strong immune response. The mechanism of reactive arthritis is related to how these liposaccharides interact with class 1 major histocompatibility complexes, or MHC1 molecules. Most patients who develop reactive arthritis have the specific gene HLA-B27, which codes for the immune molecule MHC1. The HLA-B27 gene is associated with 5 inflammatory diseases: reactive arthritis, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease-associated arthritis, and undifferentiated seronegative spondyloarthropathies. And these diseases as a group are referred to as seronegative spondyloarthropathies. They're all autoimmune inflammatory joint diseases that are seronegative, meaning that there is no rheumatoid factor present on labs, but testing for HLA-B27 gene will often be positive. Okay, back to reactive arthritis. Symptoms normally start a few weeks after an infection, and typically only the joints are affected. However, other tissues can be involved too, including the urethral lining and conjunctiva. This triad of arthritis, conjunctivitis, and urethritis is referred to as Reiter's syndrome, but it's not that common. The memory hack for the reactive arthritis triad is can't see, can't pee, can't climb a tree. Okay, so just remember that arthritis is the most common symptom, and it typically presents as pain and swelling of a single large joint, like the knee. Also, rarely, patients can present with keratoderma blennoragicum, which is hyperkeratotic lesions of the soles and palms. So diagnosis of reactive arthritis is made by a history of infection, clinical exam, and a positive HLA-B27 gene. And arthrocentesis of synovial fluid will show a negative bacterial culture, meaning it's aseptic. First-line treatment is NSAIDs for the pain and inflammation. If there's no response, methotrexate or sulfasalazine can be tried, or steroids. And if the patient still has a precipitating infection like chlamydia, treat that with antibiotics. Overuse syndrome is simply the result of repetitive stresses and microtrauma that occur without allowing the body time to heal. These injuries can either be caused by improper technique or actual overuse. Symptoms include tenderness, stiffness, or tingling in the affected region, and treatment includes anti-inflammatories, physical therapy, and activity modification. Plantar fasciitis is inflammation of the plantar fascia in the feet that occurs with overuse, especially in athletes or in patients with flat feet or a heel spur. Symptoms include heel pain and tenderness on the plantar surface, the bottom of the foot, usually at the calcaneal insertion of plantar fascia with weight bearing, especially in the morning or with the initiation of walking after a long rest. Pain usually decreases throughout the day. Diagnosis might include an X-ray to show evidence of flat feet or a heel spur, but diagnosis can also be made clinically. Treatment usually includes rest, ice, NSAIDs, plantar stretching exercises, heel or arch support, and corticosteroids and surgery are options in very severe cases. The next topic is bursitis and tendonitis. Bursitis is inflammation of the bursa, which are small fluid-filled sacs that reduce friction in joints. It's commonly caused by either trauma or overuse, and it presents with pain and swelling and can persist for weeks. Prepatellar bursitis and subacromial bursitis are two common locations. Prepatellar bursitis occurs in the bursa in front of the kneecap, and it's also called housemaid's knee because it can occur with excessive kneeling, like scrubbing floors. It's also common in wrestlers and can become septic bursitis in wrestlers, so do an aspiration with gram stain and culture in these patients. Subacromial bursitis occurs above the supraspinatus muscle in the shoulder and below the acromion. This bursitis has pain with motion and at rest and presents similarly to subacromial impingement. General treatment of bursitis is rest, NSAIDs for the inflammation and pain, and sometimes a brace or a wrap. Tendonitis is inflammation of a tendon, which is a cord of fibrous tissue that connects muscle to bone. It's commonly caused by overuse injuries or systemic disease, like arthritis. Patients have pain with movement, swelling, impaired function, and it resolves over several weeks, but recurrence is common. Patellar tendonitis and biceps tendonitis are two common locations. Patellar tendonitis causes anterior knee pain, swelling, and tenderness at the inferior border of the patella. It's also called jumper's knee because it's so common in jumping athletes. Additionally, steroid injections, which are sometimes used to treat tendonitis, are contraindicated at this location due to a high risk of patellar tendon rupture. So biceps tendonitis causes pain in the biceps groove at the anterior shoulder. There's pain with resisted supination of the elbow. And if there's a Popeye deformity, then that indicates an actual biceps tendon rupture. Other special tests for biceps tendonitis are the speed test and Yergesen test, which are positive if pain is reproduced. So diagnosis of any tendonitis is primarily clinical, and imaging is not usually necessary. But if it's done, an ultrasound or MRI can both show tendon thickening. General treatment of tendonitis is rest, ice, light stretching, and possibly steroid injection depending on the symptoms and location. And NSAIDs aren't as much help here because they don't penetrate the tendon circulation. The next topic is sprains and strains. By definition, a sprain is a ligament injury, and a strain is a muscle or tendon injury. Their symptoms, however, are very similar. But let's start with sprains. So ligaments connect bone to bone. When ligaments get overstretched or even tear, this is a sprain. It presents with pain, bruising, swelling, decreased range of motion, and reduced flexibility. And the ankle is the most commonly sprained joint. There are 3 classifications of sprain severity. A first degree or mild sprain means that the fibers of the ligament are stretched but intact. A second degree or moderate sprain is the tear of a ligament. At least a third to almost all of the fibers of the ligament are torn. And a third degree or severe sprain is a complete rupture of the ligament, and sometimes a piece of the bone gets avulsed too. So now on to strains, which involve tendons or muscles. And tendons connect muscles to bone. When these get strained, symptoms can include pain, muscle spasm, swelling, decreased range of motion, and reduced flexibility. Very similar to sprains. And the most common location of strains are the hamstrings and the lower back. There are 3 classifications of strain severity. A first-degree strain is the most mild, and it occurs when there is a little bit of tissue tearing, mild tenderness, and pain with full range of motion. A second-degree strain occurs when muscle or tendon tissue tears, resulting in painful limited motion, possibly with some swelling or depression at the injury site. And a third-degree strain, which is the most severe, occurs with limited to no movement from that muscle and severe acute pain. These diagnoses are made clinically, but depending on the injury, an X-ray or MRI is often ordered to rule out fractures or additional injuries. Treatment is RICE, which is rest, ice, compression, and elevation, and NSAIDs for pain. For severe sprains or strains, surgery might actually be required to repair torn or ruptured ligaments, tendons, or muscles. Costochondritis is inflammation of the cartilage that connects the ribs to the sternum. So that includes the costochondral, costosternal, and sternoclavicular joints. It's common after a viral infection or with musculoskeletal trauma, and it causes pleuritic chest pain and tenderness at the breastbone that gets worse with deep breaths or coughing. Pain is reproduced with palpation. Risk factors include older adults, high-impact sports, manual labor, allergies, rheumatoid arthritis, ankylosing spondylitis, and reactive arthritis. Diagnosis is made by X-ray, but consider an EKG to rule out other conditions. Treatment for costochondritis is NSAIDs to help with the pain and inflammation. Physical therapy or local steroid injections can also be considered. A ganglion cyst is a benign, fluid-filled synovial cyst that might have been caused by either trauma, mucoid degeneration, or synovial herniation. They usually appear on the dorsal aspect of the hand as a firm and well-circumscribed mass or ball. They'll be fixed to deep tissue, but not to the skin, and they'll transilluminate. You can also perform an Allen's test, the same one used in thoracic outlet syndrome, in order to ensure radial and ulnar arterial blood flow. Treatment is usually just observation, but aspiration of the fluid can be done if needed, or excision removal in severe cases. Gout is an inflammatory disease characterized by the accumulation of monosodium urate crystals in the soft tissue, joints, and bones. It's most commonly due to underexcretion of uric acid. Gouty attacks are secondary to purine-rich foods like alcohol, red meat, organ meat, and shellfish. These foods cause rapid changes in uric acid concentration. Attacks can also be secondary to medications like thiazide and loop diuretics, ACE inhibitors, pyrazinamide and ethambutol, which are the tuberculosis drugs, aspirin, and ARBs, except for losartan, which actually decreases uric acid levels. So let's talk biochemistry for a minute. Purines are a component of nucleic acids, like DNA and RNA, and when they're broken down in the body, purines are converted into uric acid. Uric acid can be filtered out of the blood and excreted by the kidneys in urine. But when it's in the body, uric acid is not very soluble in bodily fluids, and when it exceeds its solubility, we get hyperuricemia. Uric acid in the body then loses a proton and binds to sodium, forming monosodium urate crystals. So in a gouty attack, hyperuricemia leads to monosodium urate crystals being deposited in joints, and the joints become red, hot, tender, and swollen within hours. Acute gouty arthritis is often seen in just a single joint, most commonly the first metatarsal phalangeal joint, which is called podagra. Knees, feet, and ankles are also common. Repeated gouty attacks can lead to destruction of the joint tissues, resulting in arthritis. Tophi, which can occur after 10 to 20 years of chronic hyperuricemia, is the formation of permanent deposits of urate crystals along the bones just beneath the skin. Hyperuricemia can also affect the kidneys, causing uric acid stones, glomerulonephritis, and even renal failure in severe cases. Diagnosis is made by arthrocentesis, which shows negatively birefringent, needle-shaped urate crystals. Also, serum uric acid level will be greater than 8, but this alone isn't diagnostic. You actually have to do the arthrocentesis. Also, x-rays will show rat bite or punched-out erosions. Treatment includes dietary changes to decrease purines, so avoid too much red meat, organ meat, shellfish, and alcohol. NSAIDs are the drug of choice for acute attacks, specifically endomethacin and naproxen, but avoid aspirin since it can increase serum uric acid. Colchicine is second line, but it has a lot of GI side effects. And steroids can be prescribed if other meds aren't enough or if the patient can't take NSAIDs. In the management of chronic gout, to try and prevent acute attacks, allopurinol is first line. Allopurinol reduces uric acid production by inhibiting xanthine oxidase, and it increases uric acid excretion. It can also cause some GI irritation, though, and has to be used with caution if the patient has kidney disease. Also, allopurinol should not be started in an acute attack. Wait until after the attack has subsided. Another option for chronic gout is febuxostat, which is safe in kidney disease patients. Colchicine can also be used in chronic as well as acute gout treatment. And if the patient is also being treated for hypertension, consider using losartan for that, since it decreases uric acid levels. Lastly, a quick note about pseudogout. Pseudogout resembles gout and causes red, swollen, tender joints, most commonly the knee. It's caused by calcium pyrophosphate dihydrate deposition in the joints. Diagnosis is made by arthrocentesis, just like gout, but pseudogout will show positively birefringent, rhomboid-shaped crystals. I remember this because pseudogout starts with a P, and so does positively birefringent. Treatment is intra-articular corticosteroids as first-line therapy, followed by NSAIDs. Colchicine can be used again for both acute attacks or prophylaxis. So let's review. Gout is caused by monosodium urate in the joints and is most common in adult men, while pseudogout is caused by calcium pyrophosphate dihydrate and is most common in elderly women. Arthrocentesis in gout will show negatively birefringent needle-shaped crystals in the synovial fluid, while pseudogout will show positively birefringent rhomboid-shaped crystals. Gout occurs most often in the first metatarsal phalangeal joint, called podagra, and is typically monoarticular in the lower extremities. Pseudogout can occur in the knees, wrists, elbows, MCP and MTP joints. Acute gout attacks are treated with NSAIDs as first line and colchicine as second line, and possibly corticosteroids. Chronic gout is managed with uric acid lowering agents, most commonly allopurinol. Acute pseudogout attacks are treated with intra-articular steroids as first line, and second line is NSAIDs and colchicine. Chronic pseudogout is managed with NSAIDs or colchicine as well. And that wraps up gout. Systemic lupus erythematosus is a chronic, multi-organ autoimmune disorder of connective tissues. It is a type 3 hypersensitivity reaction. It's also most common in females of childbearing age and can occur as a result of genetics, sun exposure, infections, hormones, specifically estrogen, and some medications. When lupus is a result of meds, it's called drug-induced lupus and is characterized by positive anti-histone antibodies. It usually resolves when the drugs are stopped and is not associated with kidney or CNS damage. Drugs that can cause lupus include procainamide, hydralazine, isoniazid, and quinidine. So the process that generally leads to lupus starts with an environmental trigger, like sun exposure, which damages cells and causes apoptosis, or programmed cell death. And the damaged cells release nuclear antigens. This is where the genetics component comes in. If the person has genes that reduce their ability to clear these damaged cells and their nuclear antigens, then there are a lot of nuclear antigens hanging out in the blood. Their genetics also cause their immune system to see these nuclear antigens as foreign and form anti-nuclear antibodies, or ANA, that bind to them. They then deposit in various tissues, which causes inflammation. And this is what causes most of the symptoms of lupus. But because lupus can affect any organ system and presents with such a wide variety of symptoms, diagnosis is often difficult. So let's go through symptoms before we get into diagnosis. Lupus has a triad of symptoms to know, and these are joint pain, fever, and a malar butterfly rash, which is a fixed erythematous rash of the cheeks and nose that spares the nasolabial folds. Lupus also presents with fatigue and serositis, which is an inflammation of serous membranes, like the lung pleura or pericardium. It's worth mentioning that lupus can affect any layer of the heart and cause pericarditis, myocarditis, or endocarditis. Endocarditis from lupus presents as Libman-Sachs endocarditis and is characterized by vegetations around the mitral valve. Other lupus symptoms include a discoid rash, which appears as round or annular erythematous patches on the face and scalp that heal with scarring. And when lupus becomes systemic, it also affects the CNS and cardiovascular symptoms and can cause glomerulonephritis, retinitis, oral ulcers, and alopecia as well. Diagnosis of lupus starts with a positive anti-nuclear antibody, or ANA test, which is the best initial test since it's very sensitive and found in almost all lupus patients. It's not specific to lupus though, since ANA is seen in other autoimmune diseases. So if it's positive, then more tests are needed. But if it's negative, then we can rule out lupus. Rheumatoid factor will also be positive in lupus, but this test is also not specific. So after a positive ANA, check for anti-double-stranded DNA and anti-Smith antibodies. These tests are specific for lupus, meaning that if they're positive, then the patient definitely has lupus. But they're not sensitive, since not all lupus patients will have them, so they can't rule out lupus. Another antibody is anti-phospholipid antibody. This one is less specific since it can be found in other conditions, but it's important to test for because some lupus patients can develop antiphospholipid syndrome, where the antiphospholipid antibodies cause a hypercoagulable state. These patients are prone to blood clots and often end up needing lifelong anticoagulation. Okay, another way to diagnose lupus is to meet 4 of the following 11 criteria: a malar butterfly rash, discoid rash, photosensitivity or rashes from sun exposure, mucosal involvement or oral ulcers, serositis like pleuritis or pericarditis, joint arthritis, renal symptoms like proteinuria or glomerular nephritis, neurologic disorders like seizures, hematologic disorders like anemia or thrombocytopenia, a positive ANA, or positive for other antibodies like anti-Smith or anti-dsDNA and anti-phospholipid antibodies. Lupus is generally characterized by periods of flare-ups and periods of remittance. Treatment is aimed at preventing flare-ups or limiting their severity. Sun protection is important to prevent the flares, and corticosteroids can be used to reduce the immune response. Hydroxychloroquine can be used for skin lesions, and NSAIDs or acetaminophen can be used for arthritis. In severe disease, consider cytotoxic drugs like methotrexate and cyclophosphamide. And that wraps up the Orthopedics and Rheumatology portion of the Family Medicine EOR Exam Study Guide. If you're listening to these videos in order, the next section is Neurology, which I'll link below once it's up. If you're listening as these videos roll out, there's a whole lot of EOR content getting uploaded at once. So stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.